I used to say to my students in the hospital, residents and so forth, that when you see a person with type 2 diabetes and that's all they have, please call me. I don't care where I am. I don't care what I'm doing. I want you to call me because I want to see that person. I want to talk to them. I want to know how they are different from all of the other people that I have seen over 50 years or so of doing this. Let me just reiterate that today, what we're really going to try to do is we're going to have what is going to be more of a conversation. And this is going to be an opportunity for you to engage in questions that you may have about many of the things that we have talked about in our chronic disease focus. Now, this is just a setup. What I'm going to do here is I'm not going to talk a very long time. I'm just going to basically deal with some issues at a very high level just to put our discussion in motion. Because you see our title, what your doctor never told you about heart disease, high blood pressure, strokes, kidney disease, and diabetes until now. What that means is that for the purpose of our discussion this morning, the gates are open. We may not know all of the answers that you have to to the questions that you have, but we want to make sure that we hear what's on your mind. And then if we don't have the answers, we'll try and get them to you at some later time. So how are we going to do this? What I'm going to do first and foremost is to talk about some of our new realities in how we are now confronting major diseases in our communities. They are on the rise. But please be reminded, like we say very often, these diseases do not affect all groups equally. That's one of the reasons why we are engaged in this initiative. We now know a whole lot more about what causes some of these conditions and what makes them worse. But we can now seriously and meaningfully pursue not only prevention of them, but we can improve their outcomes. One of the most important things that has arisen in all of our insights and the new knowledge that we've gained is the fact that many of these conditions that we are talking about have relationships with each other. If you see one, look for another, because they rarely, if ever, occur in isolation. I used to say to my students in the hospital, residents and so forth, that when you see a person with type 2 diabetes and that's all they have, please call me. I don't care where I am. I don't care what I'm doing. I want you to call me because I want to see that person. I want to talk to them. I want to know how they are different from all of the other people that I have seen over 50 years or so of doing this. We now have testing procedures and new monitoring systems that have helped us to improve how we manage these diseases and how we can slow their progression down. And then we'll talk briefly about some of the newer treatments. There are some exciting things out there, but you can't take advantage of them if you don't know about them and how they can improve your day-to-day and how they can reduce your risk of hospitalization, they can reduce your risk of dying from these conditions. And then I'm going to focus more sharply a little bit on diabetes, not because I'm an endocrinologist, but because the treatment progress that we've made in diabetes has had significant implications for other organs and other conditions like heart disease and kidney disease. Now, what kinds of questions come up? You know, the kinds of questions that have come to your mind, the kinds of questions that you've discussed with your family and friends. People want to know about major acute and chronic cardiovascular diseases. There are a lot of questions that people want to know, even when they don't ask. First, they want to know, what is all of this discussion that you're involved in this Closing the Gap initiative that CHP is involved in? What does it have to do with me? And when we talk about all of these different conditions, do I have it or can I get it? Or if I'm at risk for it, is there a way I can prevent it? And if I already have it, how do I know? if it hasn't been diagnosed, for example. And I think a lot of people are interested in what gave it to me. And one of the most important things is, can it be cured? If it can't be cured, can it be treated? And if there's treatments available, are there side effects? Is the treatment expensive? And is this treatment something that I'm going to have to do all the rest of my life? And what kinds of things should I be on the lookout for as I go on from year to year? And will this condition have an effect on the quality or the length of my life? These are just a sample of some of the kinds of questions that come up. I can tell you that these are the kinds of questions that I have engaged over the years. If we start with diabetes, and this, I'm going to consider diabetes as a core or a foundational chronic disease. Why? Because it affects so many people. Patients with type 2 diabetes, which is the predominant form of diabetes, 90 to 95% of the diabetes that we see is of this variety. These are people who are at risk for other diseases and complications. For example, if you have type 2 diabetes, there's a great likelihood that you're going to have high blood pressure or hypertension, that you're going to be overweight or obese, which constitutes a whole new set of risks, and you're going to have some lipid problems, cholesterol issues. How do we know this? Well, the fact of the matter is, when we look at the numbers, people with type 2 diabetes, over 80% also have hypertension. Almost 80% of people with type 2 diabetes are overweight or obese, okay? And almost 80% have problems with lipids, mostly cholesterol. Now look at that statement in the box. The prevalence of at least two, that is, people with diabetes have two or more of these other risk factors in approximately 90% of patients. Now, if you think about it, what are some of the highest level risk factors for heart attacks and strokes? You've heard all of us talk about it over and over again. High blood pressure, high cholesterol, overweight, and obesity. Okay? It's no wonder then that people with diabetes have all of these different complications. Now, some of the complications are because of the high blood sugar that is associated with diabetes. But please be mindful of the fact that the high blood sugar in diabetes is not the only thing that we worry about. But high blood sugar in and of itself carries with it the risk of certain kinds of complications, the eye disease, for example, the nerve disease. But it's this combination of these other risk factors, the high blood pressure, the high cholesterol, that gives you the likelihood of stroke, myocardial infarction or heart attacks, and other kinds of vascular diseases like hardening of the arteries. Now, why we spend so much time talking about diabetes as a core disease? Well, this is the heart of what we are concerned with. Non-Hispanic, Black, or African Americans are 1.4 times, that is 40% more likely than non-Hispanic white adults to be diagnosed with diabetes. 40% higher likelihood. Non-Hispanic, Black, or African American adults were admitted to the hospital. This is 2020 data for uncontrolled diabetes at nearly 4 times the rate of non-Hispanic whites. In 2021, non-Hispanic, Black, or African Americans were 40% more likely to die from diabetes. Hispanic adults were 60% more likely than non-Hispanic whites to be diagnosed with diabetes by a physician. And in 2020, Hispanics were 1.5 times, 50% more likely than non-Hispanic whites to die from diabetes. Now, when you think about the fact that there are 38 million folks in this country with diabetes, another 98 million that have the forerunner condition, pre-diabetes, this is a lot of diabetes, and this is a disease that disproportionately affects communities of color. So let's talk briefly about risk factors. What are the risk factors for getting diabetes? Well, there are two categories. I want to talk about one you can't change. But the ones that we focus on, the ones that you and I need to discuss, are the ones that you can, because these are the ones that we want to spend our time on. The ones that you can't change: age. Your risk for diabetes goes up as you get older. Your race and ethnicity. We talked about more diabetes occurring in communities of color. We can't change our race and ethnicity. There are people, that who've tried, but you know what? You can't. Your gender. Well, I'm not going to get into that. And then your family history. You can't change your genes. But the ones that are on the list that you can change: tobacco use. You can stop smoking, and you must. Healthier eating. You need to do that. Increase physical activity. Decreasing alcohol consumption. Decrease your body weight. More importantly, not just your body weight, but the percent of your body that is represented by fat. And then what we didn't know that we now know a lot better: there are certain infectious diseases that increase your likelihood of getting diabetes. COVID, HIV, and then this one that might surprise you here: poor information sources. There are things coming out now on social media, television, poor information, people telling us things that, quite frankly, are nothing but rumor and innuendo. No facts, no evidence. Poor information is leading a lot of people down the garden path and high risk for diabetes. Why do people die? Major cause of death from diabetes: heart disease. But in that category of heart disease, remember, are different kinds of outcomes: heart attacks, heart failure, even kidney disease, which is much more likely to result in death from heart disease, is all contained in that heart disease category. You can see that that's overwhelmingly the leading cause. And then, of course, there's a significant piece of this pie represented by stroke. Now, stroke is important because stroke rates are not falling. But think about what stroke represents. That's a brain problem, the blood vessels in the brain. The incidence levels are increasing, just like heart failure and atrial fibrillation. You hear Lou Alcindor, the old Lou Alcindor, Abdul Jabbar. He has atrial fibrillation. That's a high risk for stroke. That's a heart problem. But think, all of these things drive increases in stroke risk, but diabetes rates are on the increase, and diabetes also contributes to increased stroke rates. All of these things are interconnected. A brain problem that's driven by a heart problem, and a heart problem that's driven by a metabolic disease like diabetes. And then, of course, as we have an older population, we're getting more and more increase in the number of strokes every year. Well, you might want to know what are some of the risk factors then for heart disease. And you're going to notice something here. Among the risk factors that you can't change and the ones that you can change, there's a lot of similarity from one disease to the other. That's an indication of just how interrelated and how closely connected these diseases are. All right, heart disease. The risk that you can't change: age. The older you are, the higher your risk. Now, some folks, they paint, they do all kinds of, they paint themselves up, they get tucks and shots, and they look younger, but you know what the fact of the matter is? You might look younger, but you're still old. You still are at the same risk. Sex, you can't change that. I mean, in women, your risk of heart disease and stroke increases after menopause. Your family and medical history, that's your genetic component. If you have
Doc, careful how you say it now. You may look young, man, but you're still old.
Absolutely. And just be careful. But the fact of the matter is, you want to make sure that you do things that will keep you physiologically young. Okay. But remember that you have to now, as you get older chronologically, as you add those years, the urgency for doing healthier things goes higher, because now you got to try to offset those chronological years by making sure that physiologically you're younger. And how do we do that?
Yeah.
Healthier eating, better exercise.
Yeah, what I was just saying is it's kind of like a little daycare, a little bit, I guess. I'm a cosmetic surgeon too, right? And I tell
Yes,
people what you just said all the time. I can make you look better on the outside, but you are your stated age on the inside because that's your protoplasm. Your
that's exactly
protoplasm, 5 years old, your protoplasm is 65 years young. If you're 90 years old, you may look good. You may come see Dr. Reynolds or somebody else to do a little face thing or whatever. You may look very young, but your protoplasm is very old. I'm through.
and that's exactly why all of that beautiful work that you do to make people look younger has to be matched by things that we do on the inside so that they can keep up with that physiologically. Okay? Because the things that we can change are blood pressure, high cholesterol. Remember that the lousy cholesterol, the LDL, is what we're really targeting. Smoking, excess body fat, and especially central fat. If your body fat distribution is mostly upper around the waist, that's the most dangerous kind of fat. Okay? It's much more dangerous than hippie fat. Okay? Physical inactivity. That is when you don't get enough exercise. Those are things that you can change. Excessive alcohol intake, poorly managed diabetes. These are the risk factors for heart disease. If you think back about what I said about the risk factors for diabetes, and now we're talking about the risk factors for heart disease, there's a lot of overlap here. And when you look at heart failure, which is a major cause of mortality and morbidity and hospitalization, the early stages of heart failure, look at look at the things that cluster in stage A. This is before you even know you have heart failure. High blood pressure, diabetes, there it is again, coronary artery disease, and your family history. So we have to make sure that we get our focus on these risk factors so that we can stop some of these major chronic diseases that send us to the hospital and cause early death. And this is the relationship that you're going to hear about a lot. Cardiovascular disease, the heart diseases, and kidney diseases, they're closely interconnected. You know that 40% of people who are diagnosed with diabetes already have some underlying kidney disease. They don't even know it. That's because the kidney disease and the heart failure, early heart failure, are things that can happen early in the course of diabetes, even before you are diagnosed. And when you get problems in one organ system, like your kidneys, look out. You're going to have a high degree of likelihood that you got problems in another system like your heart. Look at the box. Renal, that is kidney, and cardiac, that is heart systems, are inextricably linked. They are closely connected and should be always considered together. It is now well established that the earliest heart complications in the setting of diabetes are what? Kidney disease and heart failure. Those are the things that show up early. And then finally, think about the risk factors for kidney disease. This is starting to sound like a broken record. The ones that you can't change. Well, high blood pressure, heart disease, and heart failure. If you have these things already, they already have made major contributions to your kidney disease. If you're over the age of 60, if you have a personal history of acute kidney injury, if you're a smoker, the things that you have to really focus on: a better diet. This is especially true in kidney disease. People don't think about the fact that it is important to be more physically active when you have kidney disease. It is a powerful tool. Managing your weight if you have kidney disease, very powerful. Quit smoking, limit alcohol. Certain pain relievers like ibuprofen and non-steroidal pain relievers, they can damage your kidneys. These are things that we need to be mindful of. And then getting regular testing of what your status is in your kidneys. There are two different kinds of tests. We won't go into detail about that right now, but you really need to have these tests done so you'll know, where are you? Have you progressed? Because certain levels of progression are associated with poor outcomes and increased risk of death and heart attacks. You got to manage your blood pressure to reduce the progression of kidney disease. You got to manage your diabetes to reduce the progression of kidney disease. And it is important to keep your cholesterol in the target range. The good news is that we have now medicines that can really help us with this. And this is something I want you to really cement in your mind. Death, coronary heart disease death rates, if you have no diabetes in these gold bars, notice that you have no death, no risk factors. That's your lowest death rates. One risk factor, your death rate doesn't change very much if you have no diabetes. But if you have diabetes, even the presence of one risk factor, we're talking about diabetes plus high blood pressure, diabetes plus high cholesterol, diabetes plus cigarette smoking, diabetes plus excessive body fat. One risk factor in the presence of diabetes, and look at what happens to your death rates from coronary heart disease compared to a person who doesn't have diabetes. If you have two risk factors on top of your diabetes, now your death rates go even higher. And three risk factors, you see the pattern here. The more risk factors you cluster, the greater your likelihood is, especially in the presence of diabetes, the greater your likelihood is of having a cardiovascular death. Now, let's just end this with this. What is causing this rising incidence of diabetes, heart, kidney disease in the US and other countries? Why are we seeing so much? Well, one of the questions that we have to ask, are the deadly sins at work? Is this gluttony or is this sloth? If you think back the way it used to be back in the day, I don't know how many of you ever gone to a Jack in the Box, but they had this thing called a bacon ultimate cheeseburger. That one sandwich alone had over 1,000 calories. That's just a sandwich. 71 grams of fat in that one sandwich. And then when you couple that to the fact that nowadays the average American child or teen watches 4 to 6 hours of TV or these devices every day, that you're not doing a lot of activity there. We used to, back in the day, used to have French fries that came in servings that had about 200 calories. Now, how many calories do you think were in those supersized fries that we used to have? Well, 3 times as many. Now that's 400 more calories than we used to get. How much exercise do you think it takes to burn off those extra 400 calories? Well, if you weigh about 130 pounds, you would have to walk 2 hours and 20 minutes at a reasonable pace to burn off 400 calories, those extra calories that you would accumulate from just that excess ingestion of French fries. So and then we got problems like this. There's some people who have a very imaginative approach to exercise. You know, folks have come up with walking the dog in ways like this. You see, the dog is walking, but what is he doing? You see what's in his hand? The point is that we got some work to do, okay? And these are the two principles that you're going to hear us shout all the time. That for prevention and for improvement in all of the chronic diseases that we talk about, whether it's diabetes, heart disease, kidney disease, high blood pressure, obesity, stroke risk, less than you're doing now. What does that mean? You got to push back. You got to cut back on the calories. You got to cut back on the percent fat. You got to cut back on those things like salt ingestion. You got to do less than you're doing now. We're not saying that you necessarily have to change and destroy your eating patterns, but you definitely have to do less as a first step and then work towards healthier. And then the second part of that is more than you're doing now. You got to do more physical activity. Start with 1 day walking. Walk a block or two. And then 2 days. But you got to do more than you're doing now when it comes to physical activity. There are lots of places that you can go to get good information. There's a program called the National Diabetes Education Program that's sponsored jointly by the NIH and the CDC. Now, however long they last, that's a different story. But you know, you can talk about managing diabetes, and they give you all of the things that you need to do, and you'll see different little sayings like this. It's not easy, but it's worth it because of the outcomes. You can see it in Spanish. In fact, they've gotten it done in about 18 different languages. Okay, and then this is the final slide next to the resources. The progress that has been made in the treatment of diabetes has had far-reaching effects. The reason you're going to hear so much about diabetes is because two different classes of drugs that have been added in the treatment of diabetes, these GLP-1s, you hear about them on television. Mostly you hear about them, about their effects on weight, the Ozempics of the world. And the SGLT2 inhibitors, you hear them like the Jardiance and the Farxigas. These two different classes of medications that have been added in the treatment possibility for diabetes cause lowering of your A1C. They improve blood sugar. They were approved as diabetes drugs, but you know what else they've been shown to do? They can now reduce and prevent heart failure. They can slow down and really prevent atherosclerotic cardiovascular disease like events like heart attacks. And they can slow down or even prevent the development of kidney disease. So you ask, can people with diabetes get benefits like this? Of course they can. But we also now know that people without diabetes from these drugs can benefit from the cardiovascular prevention that's provided by these agents, and they can benefit from the kidney disease prevention provided by these agents. These have been game changers, and that's why they have really been highlighted so much. Now, you can go to a lot of places to find information that will offset some of this poor information that's out there now. You can find out about diabetes from all of these. This is just a sample of some of the websites that are out there that give you evidence-based information. You can find out about heart disease, the American Heart Association, the American College of Cardiology, the HFSA, that's the Heart Failure Society of America. There's a special organization that's devoted to just heart failure, stroke prevention. There's a stroke association in this country. There are organizations devoted to helping you find out about how to prevent it and how to take better care of it if you've ever had a problem with such a condition. Kidney disease, the Kidney Foundation, there are renal and kidney associations that are out there giving excellent information on what people can do to reduce their risk of developing kidney disease or improving their outcomes if they have kidney disease or stop it from getting worse. And then there are others. And I put in there, you see ADCES, the Association of Diabetes Care and Education Specialists. Diabetes educators have a powerful website for practical things that you can do to help manage your life, your quality of life, especially your diabetes. And then there's this group called CHP Health. Okay, this is an organization that's doing things like you're participating in right now, where you can get information on the one hand, but you can have access to people who can provide you with where to go and with insights on what you can do to prevent and control these different chronic diseases. This is a challenging journey. We know that. A lot of challenges, but there are now so many opportunities for improved outcomes, provided we work together and work diligently to solve problems and overcome obstacles to success. One thing you can be assured of, and that is in the face of all of these challenges, we will never, ever give up. Even when we are caught in the jaws of the enemy, we're going to keep fighting until the end. That's why we're doing what we're doing now. So I'm going to stop right there, and I'm going to turn it back over to you, Dr. Reynolds, because I hope that people have at least been prompted to think about questions that they maybe have wanted to ask, but maybe have never had a chance to.
So, Dr. Gavin, and to each and every one here, question with a little commentary, and you've answered this previously. I'm 60 at this very moment. I have a classmate that we're putting to rest. And as he was there these last 2 days, we kind of noticed something you talked about earlier. George looks healthy, moving, but all of a sudden he crashed. A lot of these internal diseases, even when you're young, I think his body was old inside. So here's the question. What is it about our DNA, people of color, that attracts diabetes and the associated diseases around it? You've answered it before, but I guess I need to hear it again.
Yeah, it's a complex issue. One of the things that we know is this: we are people who genetically we developed in a way that we were suited to live in a different place and in a different way. We were brought here forcibly. Okay, and a lifestyle was imposed upon us that would not necessarily have been our lifestyle at all. But our genes haven't changed. Okay, and so when you now take genes that were meant to thrive in a tropical setting, for example, in a setting where you were going to mostly be farming and eating very differently. Now you're in a situation where you're under a lot of different stresses. You're eating a diet that was not necessarily meant for you. Okay. Now that clash between how you are constituted as a person and how you are forced to live, that's a combination that works to our disadvantages. To our disadvantage. For example, I'm going to give you a very concrete example, Pastor Philpott. There's a group called the Pima Indians in Arizona. They lived around the Gila River, and they farmed, they fished the Gila River until settlers came in, dammed up the river in the 1800s, and now they had to stop farming, and they couldn't fish. Well, the first case of diabetes in the Pima Indians wasn't recorded until around 1908. Okay, but when they had to become a reservation because they couldn't fish, they couldn't farm anymore. At the reservation, they started eating government commodities. They started eating bacon. They started eating, plain flour, white flour, not brown wheat like they used to be. Their diets changed completely. A group of those Pimas who didn't want to live on a reservation left Arizona and went to northern Mexico. They lived in the mountains. Okay, and they went back to farming and doing things like that. Well, the diabetes researcher Elliot Joslin out of Boston came down to the Pima Indian Reservation to do research and found that in a period of about 20 years, once the reservation had been established, diabetes rates in the Pimas had gone up 40-fold. Those Pimas that went to northern Mexico, their diabetes rates had not increased from before. But also their body weights had not changed. They were doing physical activity, they were farming, they were still doing the kinds of things that they had been doing all along in their history. But the ones who now were living on the reservation, they were living a different life, eating a different diet. Their obesity rates had gone up. So the clash between our genes and our lifestyles is what causes so much of what we see now as these kinds of chronic disease expressions. I say this all the time. Your genetics can load the gun, but it's your lifestyle that pulls the trigger. What can you change? Can't change your genes. Those Pima Indians that went to northern Mexico didn't change their genes. What they changed was they changed their lifestyles. That's why we put so much emphasis on this. We have to be so very careful about how we live. And the final thing that I would say is this. We've learned now that something called the social determinants of health, how we live, the stress we're under, the environments that we find ourselves in, the pollutants and all those, we found that those things really make a difference in the rate that we develop some of these kinds of diseases and the rate that they progress. And that's why we put so much emphasis on prevention, but you can't prevent what you don't know you're at risk for. That's why our knowledge base has to increase. That's why we have to make sure we go to a healthcare provider. Get yourself checked out, even if it's once a year. Because if you don't know that something's going on, by the time you do know, it may be a long way downstream. That's it. That's a long, drawn-out answer, and I apologize for that. But there's a lot of layering that occurs here. Okay.
Thank you so much.
Dr. Gavin, the question was, how often should I check my blood sugar level at home?
Okay, so checking your blood sugar is something that, quite frankly, is something that you should do if you're on insulin. You should do this as often as you can, and you can do that now by using these new continuous glucose monitors. Okay, now let's go to the low end. What is it you're trying to find out by checking your blood sugar? You're really trying to find out whether or not your insulin is keeping your blood sugar in a range that is healthy for you. Okay. Now, the least number of times that you could do that and get information that's going to be useful is going to be about 3 times, 4 times a day. That's the least number that you can do. But think about this. If you're eating 3 times a day, if you checked your blood sugar before you ate and then within 2 hours after you ate, for each one of those meals, that's a minimum of 6. That's just to find out where your blood sugar is starting before you eat and where your blood sugar is ending up after you eat. That's a minimum of 6. So what we're seeing now is that we're recommending that the way you monitor your blood sugar when you're on insulin really needs to change. And it can change by using these new tools called continuous glucose monitors, CGM. Now, what is that? It's a device. It's like by the size of a quarter. You put it on your skin. It has a little plastic insert, little plastic needle that goes in. It's not so much a needle as it is just a little device that allows access to your the fluids in your body that reflect your bloodstream. It gives information to your phone or to a sensor to a reader that you have that lets you know what your blood sugar is doing minute to minute. And you can get 2 weeks worth of that information out of one of these things, or one of these sensors. Okay. Now, what does that do for you? It lets you know at any moment of the day, under any circumstance of your life, what your blood sugar is doing. That's just how things have changed. Now, you have the A1C. Remember, the A1C is a blood test that lets you know what your blood sugar has been doing on average for the past 3 months. But that's not a day-to-day thing. Okay. So there are different tools now that can help you know where your blood sugar is, especially if you're on insulin. But there are other times that you need to know what your blood sugar is. And that's why you'll hear us talk more about these things like CGM in the future, because we want you to know what these new tools are, what they can do. And not only that, we want to try to help you get access to them. Okay.
Doc, let's talk about that. We had a health fair at our church last week, Monday, and we had Blue Cross, Blue Shield, or Florida Blue there, and Dr. Reynolds was going in at him. I had to pull him off. So, but the theme behind that, how do you get these monitors? So I have a question for the audience. Is there anyone on this Zoom webinar that has what Dr. Gavin is speaking of? You have one of those. And then I would love for you to share what was the process. What journey did you have to take to get it? Anybody has that monitor?
I have a Dexcom 7. It was prescribed for me by my physician, and of course, my health insurance paid for it.
Mhm.
And I do use it, maybe not as much as I should, but I do use it at nighttime. It irritates me, wakes me up from time to time. Irritates that my arm, I should say. But I do use it, and it does help.
And Mr. Lovett, when you, how is that information being transmitted from your Dexcom? Is it going to your phone or
To my
do you have a
phone,
reader?
and I also have a reader. I've never used the reader, haven't connected it, but it goes straight to my phone.
And have you had the opportunity to get one of these little printouts, one of these little graphs that your information can be used to construct, and then talk about that with either a diabetes educator or with your provider?
Yes, my doctor has reviewed it, because my blood sugar was unmanaged.
Okay.
My blood sugar was at 9.1.
Okay, that's your A1C.
Yes, my A1C. Yes. My A1C was at 9.1, and he did put me on Manjaro, and
Okay.
that has helped. That's got me down in the low to mid 7.
Okay, and then if you looked at that little graph now, that little plot of what your blood sugar does from minute to minute with that
Yes.
Dexcom data, you know they have what's called a time in range. That is
Yes.
your blood sugar. They want you to keep it within between a point on the low side and a point on the high side. Between those two, it's usually between 70 on the low side and 180 on the high side. And those are the kinds of things we want people to get used to. That your time in range, so that if it spikes up, you can see, when did that happen? Did that happen on a Wednesday or a Thursday? What was I doing?
Yes.
Okay. If it goes low, when did that happen? And what was I doing at that time? So these are the kinds of things that can help you better understand how the things that you're doing are affecting your glucose control. But
And Dr. Gavin, notice Pastor Lovett said he acquired that machine through his health care plan. And Dr. Reynolds got a lot to say on that, because the Blue Cross, Blue Shield, Florida Blue people, the monies are there. We had a group of people at our church, and I'll yield to Doc, 50 diabetics. And if 3 of those persons had the machine, and we heard Florida Blue says there's a process to get the machine. Dr. Reynolds, I yield to you.
yeah,
This is the deal, guys. Medicare and Medicaid, which is paid for by a big thing called CMS, they are the payers, which is the United States government, for Medicaid and Medicaid. It's just that the money is given to the different insurance companies. Okay? But let's make sure you guys understand this. Your your Dexcom 7s, your Libre, it's on that, 2 and 3, they're all covered by Medicare and Medicaid, CMS. However, we happen to be in a capitated program, which you may not even know about, but if you have an HMO, which a lot of people do with Florida Blue, not just Florida Blue, but a lot of different insurance companies, right? And what that will do is that the doctor has to make a decision on whether or not you're going to get one of these devices or not. CMS already said you need it. It's if you to get it. But when you're under capitation, the insurance company tell these docs, put them under capitation. That means that, let's say you get 1,000 patients. I'm going to make it real quick and simple. Say they have 1,000 patients to take care of under, let's say, insurance company. They're given, on the HMOs, they're given so many dollars per month for those 1,000 people, right? If you have a large population of diabetics, be they on insulin or not, they may be on an oral hypoglycemic agent such as metformin, the doctor may choose for financial reasons to not give you a constant glucose monitor. Now I have a problem with that, big time problem with that. So I'm going to be talking about that in the news and everywhere else. I'm going to shout from the rooftops because to me that is so antithetical what we do as physicians. Okay, I always say this: if you do the right thing by God's people, the money will always follow that. But you got to take care of the people first. Second thing about what I'm saying: when these people go to the ER to see a person just like me, they're in diabetic coma, secondary to the blood sugar being so high, then what we call diabetic ketoacidosis. Guess where they go? One, they intubated, so they got to go to the unit, and I intubate them. They're going to have a real serious problem. DKA means they have a serious problem too. Their heart may even stop beating, so they go to the ICU. Okay. Guess what happened, guys? If you're under a capitated position and your insurance company is with a HMO, checks for capitation. Guess what the doctor has to do too? They have to come out of their own pocket. The capitated funds they've given them to guess what? To pay for your hospitalization, at least part of it. Okay, this is what the problem is. So if you guys have an HMO and you're not being covered because they're telling you that they don't cover it, please, please, please let me know that. We have to stop that. We have to stop the madness, and that's across the entire country. But we're starting here in Florida, so I'm your advocate. I want to make sure we speak out and speak up. As they said loud, I'm proud to do that. So that's where our was that. So here we go. All right. So was there another question, Pastor Philip? I think you had a question for me.
Dr. Reynolds, Dr. Reynolds, this is Pastor Lovett again.
Hey, Pastor
So
Lovett.
are we talking about the doctors not providing prescriptions for these monitors, or are we talking about an issue with the insurance company? I'm trying to understand.
No, it's not. It's good question. The insurance companies are given X number of dollars to take care of a patient, right? So let's say you got 100 patients, all right? And if the insurance company give you on a monthly basis, a monthly check for 100 patients that you have to take care of, okay? The doctor then has the authority to either write for something that may be somewhat expensive, although they're less than about $140 a month. Keep out of my emergency department and having a super high cost, they have to also share in also. So the bottom line is, Pastor Lovett, is that your insurance companies will tell you that yes, you're covered. You're covered for that device. But they're not going to tell you oftentimes that if the doctor's under capitation, puts all the pressure back on the doc. So if the doc is in it to make a few dollars at the expense of people that may have to be amputated, I'm going to just get real with it. Going blind, okay? Having all kinds of circulatory problems, strokes, heart attacks, we see it all through the ER. So that this has got me so passionate about what I'm talking about now. Again, I did not really get into this part of it until I was maybe 4 weeks ago. And Dr. Gavin knows I'm very, very upset about it. And we have to expose that. Again, I think that the Trump administration, Robert F. Kennedy Jr., okay, I think that if they know this and know how it really works, in terms of saving the country and the state money, my God, what do these people do when they can't go to work from amputations? There's a tremendous loss of tax revenues. But more important than that, there's something that the person can do. If you're an amputated, there's things that you cannot do. If you can't see, there's things that you can't do. You can't work. You follow me? So, in answer to your question, Pastor Lovett, the doctors they have the ability to write for a prescription for a constant glucose monitor, especially if you're on Medicare and Medicaid. That's just the bottom line. So to say that it's the insurance company's fault, not necessarily. I think it's a combination. So we have to get into that. Thank you. Take care of yourself. Be blessed.
Can I just add to that?
Question.
If I can add to that real
Please.
quickly, because one of the things that we hope to do by having these discussions and these conversations with you is to invite you to have that conversation with your provider. I mean, if you don't know about a continuous glucose monitor and what that can do for you, then you won't ask. what about one of these constant glucose, these CGM units for me? Okay, because they may still have you pricking your finger. But if you don't ask the question, what would one of these CGM units help me? Because let me tell you what the evidence shows. Okay, the evidence shows that people who use these CGMs improve their glucose control, their A1C. Pastor Lovett has already said yours went from in the 9s to the 7s. Is that correct?
That is correct.
Okay. And this has been happening routinely. But more than that, there's about an 80% decrease in hospitalizations for glucose-related diabetes events. If you go from traditional glucose testing, sticking your fingers, to using one of these CGMs. In other words, the information that you get changes your behavior. And when you change your behavior, you now reduce your risk for some of these circumstances that can get you into the kinds of trouble that Dr. Reynolds just alluded to. Okay, and that's why we really have to push the system to take advantage of what's out there that's available to you, but they're just barriers. And those barriers are in the form of reluctance on the part of certain physicians to write the prescription. Okay. And it's rarely would you have reluctance on the part of patients to use it if they are convinced that it can do them some good. And I'm telling you, the evidence is overwhelming that it can and that it will and it should. And that's where we are.
Yeah, and let me say this also, guys. I don't want to come across as being like an angry black man, but I'm an angry black man right now. I got to tell you the truth about it. Because the more I delve into it, the more I get involved in it, the more I talk to patients and also talk to doctors too, and find out that this is going on. And I'm saying, like, how could this happen? How could this actually happen? Because the big pharma is in the pocket with, I got to tell you the truth now, with a lot of our politicians. Now, they remain nameless. I don't know who they are actually, but I can tell you this one thing. If you already know that you can get it, you should be able to get it. Now you need to go out there yourself and demand answers. Answers of why can you not get it? If you're 65 and over, you should be able to have it. If you have Medicaid, you should be able to have it. Don't believe me? Google it. Will Medicaid and Medicare cover a constant glucose monitor? The answer is 100% yes. The only question is, how will they divvy up the money between the insurance company and the poor doctor dealing with? That's the bottom line. So I want you guys to become activated also. I want you guys to become activists for your own situation. And also, you got to be your own advocate. So I'm your advocate too.
That's a good thing, Doc. I think the first base takeaway for me, Dr. Gavin said it, and Doc, you just reiterated it. We now are knowledgeable, and we know that we should be asking. Did anybody know, Pastor Carter, I don't know if he's still on, that you should check your feet once a year? You should check your eyes once a year. Dr. Gavin, elaborate on that. That's what Dr. told us in the chat.
There are things that, listen, I know you can't see this, but this is a volume that comes from the American Diabetes Association every January. It's called Diabetes Care, okay? It's the standards of care for diabetes. This is the Bible for how we should be taking care of diabetes in a way that prevents complications, that uses all of the technology. It tells you what to do and what not to do, okay? It includes things like, yes, you need to have an annual eye exam by a person who's certified to do that. You need to be checking your feet professionally by a person who's certified to do that, but then you need to be taught how to check your own feet. And you need to be able to do that. You can't check your own eyes necessarily, but you can check your own feet. You can check your skin. Okay, there are things here about natural supplements and herbs. Listen, you can find on the internet and on social media all of these slick videos populated by actors who sound so sincere and like they have all of the evidence in the world that by drinking this special concoction of cinnamon and beetroot and whatever else that you can cause your blood sugars to just marvelously get into the normal range. Well, you know what? Go to the Bible of diabetes care and you find out which of these supplements there is any evidence for, and quite frankly, there's very little evidence at all that these supplements can do what some of these approved, tested medications can do. When I talk to you about SGLT2 inhibitors like Farxiga, Jardiance, and Invocon, all those kinds of things, they have been tested. Those have passed the test of clinical trials and outcomes to show what can be done to prevent things that kill people and cause complications and cause hospitalizations. They've met the test. We can't say that for any of these herbal supplements. Not a one of them has gone through that and been able to show that. Okay, and then it's just important to
Dr.
keep
Gavin,
that.
I'm sorry. I have a little personal testimony of there, and I'm sure others have the same. Um, and maybe we should do a webinar on the natural. I'm 100% in favor. Apple a day keeps the doctor away, but I think that is a tit of ignorance. I have a nephew, had a heart disease, graduated from Florida State. I don't know if my mom is still on, my brother. And he was given medication to monitor his heart. He was denied the opportunity to play in the NFL, and someone in college, some smarty pants somewhere there in Tallahassee, encouraged him to do the natural thing. Well, he didn't live 2 years. He died at a very young age. And so from a spiritual perspective, I always tell people that medical doctors are servants of God, and God is a God of science. And so, yes, beets and carrots may be a very small part of a prescription or prescribed medicine. And so that hits home with me when people attempt to substitute. We have Sister Bernice Wooten. She's a member of our church. She's on. I'm living, and I had the same disease as my brother, her biological brother, prostate cancer. And we have to be very careful, because Adrian's no longer here. And I'm here because I went to a medical doctor. So I really jump in and preach a sermon when that topic comes up. Just had to put that out there. And I don't know if anybody else have any testimonies. Dr. Gavin, I yield back to you.
Well, I know I thank you for that, because that's a story that we hear all too often. The reason that I'm in endocrinology, the reason that I came into diabetes is because my family was ravaged by diabetes. Killed my great grandmother, whom we loved dearly. In fact, my sisters, my uncles. I have prediabetes. I've had prediabetes that I've known about for 13 years. I have not progressed to diabetes in all of that time. Okay, I do take certain vitamins and supplements just for general good health. But what do I do to keep my prediabetes at bay? I eat healthy, I exercise, and I take metformin once a night. Okay, because I know the data, and I every 10 months or so, even though I don't have diabetes, I wear one of those continuous glucose monitors just so I can see what my body is doing. Okay, and I have been as steady as a rock, and I've avoided progression. That as old as I am now, given my family history, I should have full-blown diabetes. I do not, but it's because I try to make sure to keep the balance between doing those things that are healthy. Those are the natural things. We should do those. But remember, those things are the kinds of things that are assisted by appropriate medications. This is not an either or. It's a balance. And we have to make sure that we meet the challenge with what tools God has provided us to do that. And our praise should be that we have now got powerful tools that we didn't have before. I wish we'd had them when my great grandmother was alive. I wish we had used them before my Uncle Tommy died, Okay, those are the kinds of things that we're trying to do now in sessions like these. Okay, that's enough of testimony from me.
Now, I want to say this thing also, guys. Dr. Gavin mentioned about your feet, right? And take care of your feet, especially if you're diabetic. Typically, the way it goes is that you get an infection. You usually walk around the house maybe with no shoes on. That's a no. You typically don't have cotton socks on. That's a no. You may step on a nail or something. That's pseudomonas, by the way. So when you get infected with that, the first thing that happens is going to be your foot. Typically, it's going to be the toe. If it's a great toe or not, it doesn't really matter. But eventually, that toe develops gangrenous gangrene. Dry gangrene is coming off, right? Then everything kind of like marches up. It's like a marching band that's going in an upward fashion, which is bad. In this case, amputation after amputation. So for me, again, I always get back to this thing called diabetes, man. I never was so passionate about diabetes till I really learned, and it's probably under the constant drilling in my head from Dr. Gavin, by the way, that yeah, diabetes is not run by itself. It has brothers and sisters, aunts and uncles. They're called hypertension. They're called strokes. They're called heart attacks. They're called kidney failure. There's a lot of stuff. They're called amputations. They're called blindness. All this stuff. So it's so critically important. Getting back to what I was going to say though, about the foot. Make sure you have Medicare and or Medicaid. You guys are entitled to get, guess what? To be seen by a podiatrist. A podiatrist. That is a foot specialist. Okay? You do not want anybody clipping your toenails, amen, that do not know how to clip toenails. But if you're clipping the wrong way, guess what happens? You get an infection. I'm just keeping it real, guys. So if you're diabetic, you should be getting a foot evaluation once a year from, guess what? A podiatrist, not from your primary care doc. Primary care doc cannot clip my toenails. I'm concerned about that stuff. You got to see the foot care professionals, and those are called podiatrists. I'll leave it there.
Question in the chat, Dr. Reynolds, Dr. Gavin, can type 2 diabetes go into remission? I think I'm phrasing that correctly.
Oh, yeah. Oh, I love that question. Thank you for that question, because that's one of the most exciting things that has happened in recent years, okay? That it has been demonstrated in studies that have been done in fairly large numbers of people that people who've had type 2 diabetes for periods of 1 to 2 years. Now, these are people who were less than 5 years, okay? So these studies have only been done in people who've not had diabetes, known diabetes for very long. They've been put on very low calorie diets. That was the major intervention. They put on and when I say low calories, I'm talking about these people were put on diets 500 to 700 calories a day. Now, I showed you a sandwich that had over 1,000 calories in it, but these people were put on 500 to 700 calories a day, and they were maintained on that diet for a period of several months. They went into complete remission. That means the remission is defined by all of their medications are gone, and your A1C is maintained at a level of less than 6.3% for at least 6 months. That's remission. That's the definition of remission. No medications required. Now, they don't call it cure because we don't yet have any proof that you can make it go away and it never comes back, okay? But remission has been established, but it's a very steep hill to climb. If you think that you can go on 500 to 700 calories a day and keep yourself there for a period of 6 weeks to in some cases 12 weeks, you can achieve remission. They lost weight. Many of them lost significant amounts of weight, as you might imagine, if you were able to engage in a reduced dietary intake like that. So what I do is I use that information as an indication of what you can do on the journey towards remission. Not everybody can get to 700 calories a day, but you know what? There are some people on 2,000 calories a day now that can get to 1,500. There are some people that are doing no exercise, but they can start exercising a couple of times a week. And you know what happens? Your diabetes improves. And when you build on that, if you're committed to building on that, then you're on the journey to remission. If you want to push the envelope like those people did in those studies and get to those extremes like that, remission can be achieved. The answer to your
Dr.
question is
Gavin,
mhm.
I actually put that question in there because I witnessed that with a friend of mine, and she didn't go on no 500 to 700 calorie diet. Her doctor said to her, if you was to lose 40 pounds, you would probably not need metformin or whatever she was taking. So she started the year off saying, I'm going to lose this weight. She did lose the weight. And then the next year, she actually lost 51 pounds, if I remember right. The next year, he said to her, her A1C had gotten down to a 5.4. She had been like a 7 point, whatever, whatever. And when she had 3 consecutive doctor visits every 90 days, he wanted to make sure that she was still there. So the first, he took her off one med, then he took off the next. And by the time they got to the end of the second year, she was on no meds. Her A1C was still maintaining at 5.1, 5.3. And so now it's 3 or 4 years later, she's on no medicines. She doesn't take any medicine. She still eats healthy and she still exercises. But he had an article in his office, whatever you call them, endocrinologist, I think is what it is that you go to. So he had an article and she stole the article. She took the book, the magazine, because she wanted to show it to, she wanted to show the study to other African-American people to say, sometimes just the fact that you lose this weight when you first get diagnosed and maintain healthy eating, you don't have, because so many people are like, I don't want to take that medicine. I want to take that medicine. But that's the way you have to start out as soon as you find out and then do that. But she did not go on a strict 15. She just started changing her eating, reducing her calories, but not to that. You can't almost live off 500 to 700 calories a day. You'd be too weak to go to work after a few days.
And I'm
but
glad
either way, remission is an option. And I think people have to hear that early on in a diabetic diagnosis is this could be because I've heard obesity mentioned several times. So if you look at yourself and now all of a sudden you find yourself, that may be the key to your success of taking your diabetes into remission is losing that weight, starting the exercise, and maintaining good, healthy eating habits or nutrition diet, your dietitian, and you can live without medicine. Because so many people don't want the medicines, because I do believe it too. Medicines don't cure you, they just addict you. So you have to keep taking them, keep taking them. I think our goal should be to get off medicines, not to live on medicines. That's just me.
Well, Sister, thank you for your comments. Okay, but a couple of things is really important to point out. Okay, your friend who went on whatever diet she went on, it really would be important to know, did she do that with any medication assistance?
None. No medicine and no special diet. Just reduce calories and exercise.
Let's be careful, because if she went on a diet that resulted in loss of weight, that means that diet was different from what diet she'd been on, and it would be important to know how it changed. And that's what
eating more, like you said earlier, eating more vegetables and fruits, lean meats, not frying food. She stopped eating a lot of fried food. She started, broiling or sauteing her foods. It was a change in her own. She said, I didn't want to do a diet that somebody else created because I may not be able to maintain it. But she started just trying things, where to cut calories, the bread from white bread to whole wheat. I think it's Sarah Delight's 45 calories. So that's what she did. Something she called a realistic eating for her, because she didn't want to do something someone else created, because she didn't think she would maintain it or like it. So she just started cooking. I think she even bought a book one time they called Skinny Me or something like that. Good, healthy recipes.
So she had some assistance. It's very important, but what you're pointing out here, though, is that the devil is in the details. Okay, it really is important to know what the composition of that diet is, what the calorie composition is, because what she did was probably, and again, the point that you're making, you got to individualize it as much as possible, because it's what works for you. Dr. Reynolds is saying.
Let me put my hand down. Right. Let me say this about what I'm sure that she was probably on, by the way. Should be no surprise, by the way. She was on a low carb diet. I don't even know the person, but she's on a low carb diet. I tell people this all the time. Yeah, count calories, but more importantly, count carbs. Okay. If you're taking in less than 50, 60 carbs a day, you're gonna lose weight. Bottom line. Without any exercise. But we want you to exercise, obviously, right? We want you to do some walking, whether it's walking a dog, whatever you're going to be doing, be moving, right? We want you to drink a lot of water, okay? But at the end of the day, I can almost guarantee you, Sister Williams, that the person that you're talking about, ask about what she ate. I can almost guarantee you it was a low carb diet. No, to me, no question about it.
Yes, I do know that she did do low
Okay.
carb.
Is anybody else?
She did. That is true. Low carb.
Yes, she said
I'm
it
sorry.
was low carb. So guys, we have been on the webinar as long
Yep,
as I'm
yep.
going to be in church tomorrow.
Excuse me, Doc, can you give the Bible of the diabetes care, the name of the volume again?
Oh, that book it's called Diabetes Care. That's the name of the journal, Diabetes Care, and it's published by the American Diabetes Association. And the title of the whole volume for that particular journal is Standards of Care 2025.
God bless you. God bless you. Just before I close, I just wanted to add this, Dr. Reynolds. The Minority Quality Forum invited me and a couple of pastors to DC to their annual meeting with the Black Caucus, Congressional Caucus. Back in 2009, as early, they've been doing research on what they were calling the rationalizing of healthcare. And so if you check with them, they have statistics back to 2009 on health physicians rationing out different types of care and treatment. So you might be, that might help you in what you're doing. Let us pray. Father God, we come even now to thy throne of grace, and we thank you for the great and tremendous gift of Dr. Reynolds, Dr. Gavin, and the information they shared with us today. We thank you for each and every person that's on this line with us. We know even now that we're going to carry this information, not only to our family and friends, but to whoever we meet, that we shall share what we have learned today, that we might too not only benefit ourselves, but benefit others. Lord, we ask you again to continue to support and undergird this work, the tremendous impact it is making in our community. We know you're able and we know you can, and we submit that into your care. We pray now that as we leave this place, but never from your presence, that you be with us now, continuing to guide and lead us. And we pray, give us good health. This is our prayer. In the mighty name of Jesus, we ask it all. Amen. Amen.